My name is Dr. Arun Kumar K, working in the Emergency Department, Amrita Institute of Medical Sciences. Welcome to AETCM, the Emergency Medicine channel. We continue with the pediatric emergency medicine case discussions and topic discussions also. So we have a 1-month-old male baby present to the emergency department with his mother giving history of very brief episodes of bluish discoloration of lip and staring gaze 1 hour back, followed by which he went unresponsive. She also gave history of him regaining his sensorium within a minute and then further remained asymptomatic. Currently the baby is active, alert and playful, and the vitals are within normal limits. So what are we dealing with here? How do you evaluate this child? Most of the time emergency physicians have this confusion of either admitting the child, evaluating child, or discharging the child. We don't know. Since the patient is asymptomatic currently, we cannot just discharge like any other patient is. So this is something called as ALT or BRUE. Now what is that? Now in 1986, before the risk factors of sudden infant death syndrome were well understood, an expert consensus group from the National Institute of Health coined the term ALTE, that means apparent life-threatening event, which was defined as an episode that is frightening to the caregiver and involves some combination of apnea, color change in muscle tone, choking or gagging. Unfortunately, the term ALT described a constellation of presenting symptoms rather than a diagnosis, and relied heavily on the subjective impression of non-medical caregivers. So no differentiation was made between the 80% of the ALT patients who are well appearing at the time of presentation and patients with ongoing symptoms such as respiratory discomfort or difficulty or sick looking child. To address these concerns, in 2016, American Academy of Pediatrics came with a more precise terminology called as BRUE, B-R-U-E, which is termed as brief, resolved, unexplained events. So what is BRUE then? So BRUE specifically includes infants less than 1 year old who have experienced a very brief, that is less than 1 minute symptoms, 1 minute duration of symptoms, unexplained event consisting of one or more of the following. That is, it could be the cyanosis or pallor, it could be absent, decreased or irregular breathing, marked change in tone, it could be either hypotonia or hypotonia, with or without altered mentation or altered level of responsiveness. The infant must return to his or her baseline state of health after the brief event of symptoms and having a reassuring history that and physical examination after medical evaluation, including vital signs. That means when you examine the child, the patient should have vital signs very normal. The patient should be clinically well asymptomatic and vital signs should be very much normal. So in healthy infants, 43% are reported to have a 20 second respiratory pause, and up to 5% of parents recalling seeing an infant having apnea event. So the ALT, the incidence range is almost 0.05 to 6%. So the peak incidence is between 1 week and 2 weeks of age, with the majority happening before 10 weeks of age, and the male to female ratio is almost 2:1. So what are the risk factors concerned with ALT? Now it could be either infection in the form of respiratory syncytial virus infection, prematurity, recent anesthesia, GERD, gastroesophageal reflux disease, or airway or maxillofacial abnormalities. Now, why this ALT is happening? What is the pathophysiology and how do you classify the event? Now, characterizing the event with a comprehensive history and paying particular attention in changes with breathing, skin color, muscle tone, and loss of consciousness. So you have to differentiate normal from potentially pathological events and determine what time this have occurred. Is it during the event or after the event, as well as any relationship with any sort of feeding, sleeping, and upper and lower respiratory problems. So we need to classify this children who has a disease and who appears very much normal. So in order to do that, as I termed earlier, there is a criteria which is brought inside BRU. So any infant less than 1 year of age, the patient should have very brief unexplained events, that is less than 1 minute, which consist of one or more of the following. It could be tone irregularity in the form of either hypertonia or hypotonia, respirations absent, decreased or irregular, altered level of responsiveness, color in the form of either pallor or cyanosis, and the infant must return to his or her baseline state of health after this brief event, with the parent having a reassuring history and a physical examination should be within normal limits. So how do you evaluate this person when a patient presents like this to the emergency department? So you need to have a set of questionnaire which will help you out in the emergency department. So you need to know, first of all, who observed this event. Are the parents or the caretakers? The description of the event. Was the muscle tone increased during or after the event? Were there any sort of seizure-like movements observed? Was any resuscitation required, or did any sort of event spontaneously resolve, or does it require any sort of external efforts to get resolved? Was the infant born at term or premature? Was any resuscitation required? Does the infant have any sort of significant health issues? Was there any sort of hospital admissions, ICU admissions? Were any pregnancy or labor or any delivery complications reported? Are any factors that disposed to neonatal sepsis? Has the infant previously exhibited symptoms of gastroesophageal reflux or aspiration of thin liquids? Are the newborn metabolic screening done, or if it is done, is it normal? Any previous history of any seizures or any family history of seizures, metabolic disorders, previous history of sudden infant death syndrome in the family, or unexplained death in infancy or childhood? So these are some of the questionnaires which has to be taken into consideration. And after evaluating in such like questionnaire sort of thing, then you have to address the patient should be either admitted or patient should be evaluated, anything like that. So we should consider a lot of differential diagnosis in this sort of situation. So it could be the most common factor being gastroesophageal reflux diseases, it could be upper respiratory tract infections, any sort of seizure-like episodes, it could be choking or coughing, it could be like something like periodic breathing, which is quite common in sort of infancy, any sort of pathological phenomenon like a laryngotracheomalacia, or any sort of inflicted injury also. It could be even breath holding spells. So we need to see what event is happening. So we need to like categorize event accordingly. So you need to risk stratify the concerned BRU patient. Now how do you do that? Now it is very important to know what are the factors which we call as a low risk BRU infant or a high risk BRU infant. Now to meet the criteria for low risk BRU infant, these are some of the factors. One is the age of the patient should be more than 60 days. Gestational age more than 32 weeks, and corrected gestational age should be more than 45 weeks. If that is a first incident of BRU, if the event duration is less than 1 minute, if the event doesn't require any sort of external resuscitation or CPR by any trained medical professional, or any sort of negative physical history or physical examination findings while you are meeting up the patient. Now these are terminologies which is suggestive that it could be a low risk BRU infant. Now if it is a high risk BRU infant, what is basically is whatever the factors which has been told in the low risk criteria, that is less than 2 months, any sort of history of previous episode of single episode of BRU. So what we are talking is about high risk BRU infant. That means if the patient is less than 2 months, if the patient has history of prematurity, previous history of more than 1 episode of BRU, if the event is like a more than 1 minute duration, and if the CPR is given by an external medical professional provider. Now other criteria is, one is a history concerned with child maltreatment in case of multiple versions of history or unexplained bruising. family history of sudden death in first degree relatives, feeding or respiratory problems, social and environmental issues just like probably water damage, tobacco smoke, family stresses, etc. So what do you do for it? How do you manage this case of a low risk BRU infant? The first and foremost thing is you educate the caregivers, explaining about BRU, the pathophysiology, what are the common causes, how do you come across a child when the patient is having an event like this. And then you train them how to do CPR, how to do extensive resuscitation, and then bringing back to the hospital. So you provide CPR training resource to the caregiver. And you reassure that patient bystanders in the form of parents that no need of any sort of unnecessary test or treatment in the form of either complete blood count, blood cultures, lumbar punctures, chest x-ray, or any sort of imaging modalities. And use shared decision making scales to guide disposition. And you ask them to report within like probably 24 hours to either to the pediatric OPD or to the emergency departments. So these are the strong, or I would say strong or moderate recommendation when it comes to BRU. Now BRU, like when it comes to BRU, we have a lot of hospital physicians like practicing, okay, let's monitor this patient like for maybe like 6 hours to 12 hours in the emergency department. Take a ECG to see whether any sort of arrhythmia is there, any sort of continuous pulse oximetry monitoring and all. And other tests like blood glucose, serum bicarbonate, any blood investigations. And the best thing is you should always avoid hospitalization just for cardiopulmonary monitoring. So this is all about BRU. Hope you have understood the topic. Hope you come to know like, okay, this is how we are supposed to manage BRU. Thank you all for your patient listening.